Hello, this is the voiceover PowerPoint for Nurse 1112, Skin, Hair, and Nails. So we get a lot of information about the hair, the skin, and the nails, especially the hair and the skin, when we do our general survey. So keep that in mind as we're going through the lesson here. Of course, the skin is the largest organ in your body. It covers all of you. And here is some of the functions that the skin performs. And so anytime there's a break in the skin, you've probably heard this already, anytime there's a break in the skin, there is the opportunity for infection or bacteria to enter. And so keeping the skin intact, keeping it hydrated and moist is very, very important. But you can see here all of the things that the skin does. And so it's a pretty vital, protective organ. So it's composed of three functionally related layers, the epidermis, the dermis, and then the subcutaneous layer, also known as the hypodermis. Those are the three layers. The epidermis, of course, is what we see. And so it's the thinnest layer of our skin, but it is quite protective as well. And then, of course, the dermis is the deeper portion, and then the subcutaneous layer is kind of like a supporting structure to hold everything together in a way. So the dermis, as you see here, is very vascular and lots of connective tissue, and you see the thickness can vary from different parts of the body. The blood vessels dilate and constrict in response to heat and cold, and to internal stimuli. Different things can cause that. So it also helps with blood pressure. And all these things are very, very interrelated. The dermal blood nourishes the epidermis, so the blood supply in the dermis also helps the epidermis, obviously. Nerve fibers for touch, pain, and temperature, and they stretch and contract with body movement. So we need to talk a little bit about infants, children, and adolescents just because of the skin differences. In newborn infants, their skin is can be very thin, and especially if they're premature. But there's something called lanugo, which is a very fine covering of hair on the newborn. In some instances, it can be a little more pronounced as far as color and amount, but this is a covering, if you will, along with the vernix caseosa, which is that thick, cheesy, cold cream type substance on the baby sometimes as they're born. It's like it keeps the skin from getting wrinkled in the amniotic fluid. And then sebum holds water in the skin, which produces something called milia, which looks like little pimples, little whiteheads on their nose. Those go away as well. And of course, as they age, the epidermis thickens, darkens, and becomes more lubricated, and the hair growth starts in children. And then, of course, adolescence, the sweat glands increase in number and production of sweat, of course. The subcutaneous fat deposits increase, and that's when the secondary sex characteristics start. And that's when underarm hair, pubic hair, and so forth develops. Now, the aging adult, there's some significant changes in the skin just related to aging, exposure to sun, different chemicals, and so forth. The skin loses its elasticity, and so there's more sagging and more skin folds in an elder person. The sweat and the sebaceous glands kind of decrease in number and function, which leads more to a problem of having excessively dry skin. We have something called senile purpura, which is some little darkish purplish red, small or large spots, if you will, that are due to increasing capillary fragility. In other words, the capillaries rupture a little more easily. So a little bump on the arm could make those capillaries break, and they get that typical purplish red spot, and it's under the skin. And then skin breakdown is more prevalent due to lots of factors. Cell replacement is slower, and so wound healing is delayed. So That's why often pressure injuries, pressure ulcers, whatever you want to call them, are more difficult to heal because of the aging process. And the hair, the melanocytes decrease, which leads to gray, fine hair on the head, or also sometimes on the arms and the legs and perhaps the abdomen. Now the nails are epidermal cells converted to hard plates of keratin. So nails are keratin, and there's the various parts of the nail. The white part in your nail is called lunula, which represents new nail growth. And parenchyma is the tissue adjacent to the nail. This can become injured, infected possibly, especially with some of the acrylic nail, so forth. The cuticle, of course, and then and this is very vascular, so you know anytime you bump your finger or you cut your finger, it's going to bleed quite a bit. So when we're talking about hair, skin, and nails, here are some subjective health history questions. This is not an all-inclusive list, but these are some common ones. And you can see some of the questions here. Pruritus is just another term for excessive itching. Excuse me. I'm looking up something in the book. Pardon me. Okay. So chapter 9 is about the skin, hair, and nails. Okay. I'm finding things here. All right. So the pruritus is excessive itching, rashes. What kind of medications do they take? Because sometimes those can have those side effects. Hair loss. It's normal to have a little bit of some hair loss, but excessive amounts, maybe large patches of baldness and so forth. Change in the nails, environmental or occupational hazards, and of course, anything that the patient has to say about themselves, or they may be worried about losing their hair and things of that nature. Here are some more health history questions that we would want to focus on for our older adult. They may have noticed changes. They may have some dark spots, different things that they've noticed as the years go by. Do you have problems with wound healing? That could be a result of aging. Could also be a result of possibly uncontrolled blood sugars and diabetes, all kinds of things. Any change in your feet? This is particularly true with your diabetic patient. Your toenails, lots of times the toenails really grow excessively, and older people sometimes have difficulty bending over to clip their own toenails, seeing their own toenails, and so lots of times they get really long and overgrown before they get some attention. And so we encourage them to find a good podiatrist. Bunions are uncomfortable, obviously. Can you wear most of your shoes? A lot of older people don't like to wear shoes, and they walk around in house slippers, and sometimes those are slippery and could cause falls, and they're not very supportive. So good fitting shoes is important for your whole life, actually. A history, again, of diabetes or peripheral vascular diseases is definitely going to have an impact on your skin and your nails, and possibly your hair. So in your book, there's a lot of information about different. You have pictures of things, and I will try to point those out as we go. And I'm just going to let you know that they're there. I especially don't expect you to memorize all of them, but we'll talk about them as we go, I hope. For a complete physical exam, that would be that comprehensive one that we talked way back at the beginning of the course. As you are doing your exam, you're going to do an assessment throughout your examination. If you're examining the chest, you're going to look at the skin. You're going to look at the how is it intact? Does it have, what color is it? Are there any unusual bumps or lesions or scarring, or does it look dry and flaky? You're going to do that as you examine each body system. So then you're going to possibly go into more of a focused exam maybe as we go along. You have to separate intertriginous areas. That's areas where the skin folds fall over. A large abdomen, under large breasts, in the groin, because you have to lift that up and look at that skin, because that is a great place for moisture and skin breakdown to begin, and bacteria love to live in there, so it's not unusual to find areas of yeast, other types of fungal infections. So we have to always look at that and make sure that we do that respectfully and don't embarrass the patient. Sometimes they can help hold up their abdomen, their breasts, whatever, but be very professional and kind. Always look at the feet, the toenails, and especially between the toes and on the soles of the feet as well. Now, when you're doing a specific reason for your skin assessment, maybe your patient has said, my skin is so itchy and so dry, and maybe that's why they came to the clinic, then you would do more of a focused assessment on your skin. So again, that would be something a little bit different than your complete or comprehensive physical exam. So again, we're going to get a lot of information in our general survey, as you see here. Assess the skin as one entity, giving an overall impression, and then go to specific areas and look at the distribution patterns of hair and different rashes and so forth will help you. Okay, so the first thing, of course, is we inspect and palpate the skin. We look at the color, the general pigmentation. Is it pale? Is it pale pink? Is it brown? Is it tan? Is it black? You're looking at freckles and moles and birthmarks. You're looking at those just to see where they are. Note any color changes over the entire body, such as pallor, which is extreme paleness. Erythema, also known as redness. Cyanosis is that bluish, purplish, grayish undertone sometimes. Or jaundice, yellow. Okay, now it's pretty unusual to see many of these colors in the central portion of the body, in the chest, the abdomen, and so forth. It can happen. You're probably going to notice it more in the extremities, and particularly jaundice in the eyes and the sclera. And I'll talk about that and show you some pictures. Notice if there's change is transient, does it kind of come and go, or things of that nature. The temperature of the skin, of course, we use the back of the hand to palpate. The skin should be warm, and the temperature equal bilaterally. Sometimes the hands might be cooler than the arms. The warmth suggests a normal circulatory status. Again, hands and feet may be slightly cooler in a cool environment. Pardon me. So if they're outside and it's cold and they don't have gloves and they don't have good boots, their feet can be very cold, hypothermia. And if they're outside and it's extremely hot and they may have some heat exhaustion going on, then they're going to be very, very warm. So just use the back of your hands to detect that. The moisture of the skin, we don't want to see excessive sweating or the diaphoresis. The skin should feel just very, very slightly moist. Dehydration, the skin could be very, very dry, could be flaking, could be a little bit increased in temperature. And you're going to see other things other than the skin. If someone's dehydrated, their mucous membranes are going to be pale, they're going to be dry, their lips could be cracked, different things besides the skin. But this is also a good indication of hydration status. The texture, the skin should feel smooth and firm with even surfaces. Now, of course, older people, it's going to be a little bit different. The thickness, thickened areas like calluses, maybe on the feet, maybe on the palms of the hands. Someone who works outside and does a lot of maybe a farmer building fence and things of that nature may have some callus formations on the palms of the hand. Look for edema. And typically we look for it in the feet and the ankles. By the time you find edema in, say, the sacral area, that's a pretty good indication of some heart failure issues. And so they may also have some abdominal distension. They may have some shortness of breath and some epigastric discomfort and all kinds of things. But look for that in the extremities at first. Now remember, lots of times at the end of the day, if you've been sitting for, or if you've been sitting for long periods of time, your feet will swell. That's just gravity. But we're looking at something more significant than that. Mobility and turgor, you want to check the turgor, and it should be elastic. And so remember, on the older adult, we check at the clavicle area, not the back of the hand. And they're going to look for excessive bruising and so forth. There may be tattoos and different things also there. Lesions, if they are any, we want to look at the color. Are they elevated? Do they have a specific pattern or shape? How large are they? Where are they located? And are they located in more than one place on the body? Any exudate. Exudate is another word for drainage. Is it clear? Is it yellow? Is it greenish? Does it smell bad? And then, of course, we would not typically pull out a Woods lamp. That's an advanced practice skill, and so we would not do that. It's just something that can be done, and you might see it maybe in a clinic setting or possibly in an emergency room. So I want to just point out to you on page 115, it talks about the different shapes of things that you might see, different patterns that you might see. Also, starting on page 116 through page 123 are pictures of different types of lesions, bumps and lumps and things of that nature. So I for sure want you to pay attention to these, if you would. We are going to look at page 117, something called a wheal, W-H-E-A-L. I want you to look at nodules on that same page. Vesicles on page 117, look at those. On page 118, look at a pustule, P-U-S-T-U-L-E. On page 119, scales, keloid, and of course you already know what a scar is. That's on that page, but you know what that is. On page 120, excoriation, erosion, and then on page 121, you'll see an example of a pressure injury or pressure ulcer, some pictures there. So look at those and just kind of be familiar with them. Also on page 121 is a picture of what's called petechiae, which are little flat reddish spots. And then oftentimes they're just little tiny hemorrhages under the skin, but there can be infection present with those as well. On page 122 is a picture of that purpura that we just talked about. Ecchymosis, also known as a bruise. And on page 123, let's see. And I think that's all for now. Okay. Then we're going to look at the hair. We're going to start with the scalp, and we did that a little bit last Monday. This past Monday, we looked at the head, the shape, and then we're going to palpate the scalp and the hair for surface characteristics, distribution of hair, the texture, the amount, the quantity, and the color. Smooth, scale with no scaling of the scalp, no redness, no lesions. The hair should be shiny and soft. There may be balding patterns as far as distribution with your male patient, and even some females have a male pattern baldness, and sometimes you can have both, male and female. Look for a facial and body hair distribution, quantity and texture. Is it coarse? Is it fine? Is there some scattered here and there, or is there a distribution to it? Inspect and palpate the nails, the shape and the contour. The profile sign, you view the index finger at its profile and note the angle, and there's a slide with that on there. We're not going to measure if it's 160 degrees. You'll learn these things as you go and do them more often. Look for smooth, regular, not brittle or splitting nails. The color should be pinkish to maybe a little bit pale. And of course, with ethnic variations, with African Americans or dark-skinned individuals, they may have a tannish, even a slight yellowish tinge. Check the capillary refill. Depress the nail edge to blanch and then release it, and it should come back in less than 3 seconds. If it's delayed, then that could be an indication of some circulation problem. So here is the profile sign. You can see here the different angles. The middle one is particularly indicative of pretty significant clubbing. And then the next one over is the early stages of clubbing. So here's just a little acronym that we can teach our patients about taking care of their skin themselves. And so we ask them to, sometimes if they live alone, we want them to look at back and front. Sometimes they live alone, they can't see the back, so we encourage them to hold a mirror and see if they can see anything. They may have to get a friend or a family member to look. But the A, B, C, D, E, F, asymmetry, the border irregularity, the color, the diameter, elevations, funny looking things. If they see any of those things and they're, a lot of times if they're asymmetrical, a lot of times they're not perfectly round, but they can be pretty symmetrical. The borders or the outside edges can be changing and irregular. The color may change from time to time, and they may notice that. It starts getting bigger. It's greater than 6 millimeters. It starts to get more elevated or changing even more, and it just looks funny. It doesn't look the same as maybe another spot. So we encourage them to use this, and then, of course, to report any of these things that are different to their healthcare provider. I'm not going to ask you this on an exam, but it is a good idea to kind of be familiar with it so you can tell your patients. The aging skin color and presentations, it's very thin. You can have more keratosis, scaly areas, the moisture. Xerosis is another word for really dry skin. They may have an increased number of skin tags. It gets very thin, and sometimes the vessels are easy to see. It has decreased turgor. There's decreased hair growth sometimes on the arms and the legs, and the nails don't grow as well, and sometimes they get really brittle. So those are some expected changes that you would see in your aging adult with your nails and the skin. So when we're looking at very light or very dark skin, we kind of have to be aware of those differences. Now, for dark skinned people, you don't want to check, the nail beds may not always be cyanotic. You would not be able to see the cyanosis perhaps around the mouth. So you're going to look at the palms of the hands and have them open their mouth and look in the roof of their mouth. In both of those instances, you can detect pallor, cyanosis, redness, even jaundice. And then, of course, light-skinned people, if their skin is more brown, it could be because of a result of tanning or tanning beds, or possibly exposure to some element or chemical. I'm recording. Linda, are you done? No. Sorry. So these are things that when you do, you want to look at the palms of the hands and the roof of the mouth, and then also pull the lips down and look at that mucosa. It will also give you, and the tongue, it will also give you some good information for these individuals. So sometimes patients with limited mobility, and you've heard this, I'm sure, they particularly are at risk for skin problems, specifically skin breakdown, tears, pressure injuries, and so forth. And so when we identify these patients, we always want to make sure that we check all the areas that we have skin-to-skin contact, like the obese person, the lady with large breasts, and so forth. Look at those areas, and any areas where there's pressure points, particularly the bony prominences like the hips, the sacrum, the back of the head, the elbows, the heels. Um, those kind of things are prone to pressure injuries, okay? And so people who have limited mobility or are not able to turn themselves, or they can't turn themselves very well, they can't get out of bed without assistance, we're going to be very, very careful and watch those areas very carefully. So when you turn the patient and there's a red area, maybe they were laying on their left side, and you turn them to the right side, and you notice there's a red area where they've been laying. We want to see if the skin will blanch. Okay, we'll just put some gentle pressure with a couple of our fingertips over those red areas. If the skin becomes white when the pressure is applied, and then it resumes the red appearance after the pressure is relieved, then we are still okay. But that might also mean that we need to turn them more than every 2 hours. We may need to turn them every hour and a half. So if it doesn't blanch when the pressure is applied, there's no redness, then the circulation has already been diminished, and the stage 1 pressure ulcer or pressure injury is or has already started. When patients who have limited mobility, and not only do they have limited mobility, they may be very thin, they may be protein depleted, they may be dehydrated, they may have all kinds of underlying issues like diabetes and who knows what. That's just increasing their risk factors for pressure ulcers, So stage 1, you see here, the skin is not broken, but you can see that redness and sometimes what appears to be like a little bruise underneath. Oh boy, we need to watch that. Protect that area. Stage 2, there's a little bit of a skin loss. It looked like maybe a skinned knee abrasion kind of, but the skin is open, and it's open and it's a little bit shallow, but everything, the wound bed itself is pink, which we like to see. That one needs to be protected. The stage 3 is there's full thickness skin loss with damage to the subcutaneous tissue, okay? There may be drainage and so forth. And then stage 4, everything has gone, and you can see bone, muscle, or tendon, which is horrible. There may have some eschar, which is just dead skin, or slough, which is dead skin that's progressing to eschar if we don't do something about it. And then, of course, there are some that we call unstageable, where the eschar is black, the slough is real thick, and it covers the whole wound bed, and we can't stage it until we get rid of that dead stuff. And so the key thing to remember here is you have to get the dead tissue out so that the new tissue can grow in. And there's various ways of doing that. We won't cover that here, but you've got to get rid of that or it will never heal. Here's a picture of a stage 3 pressure ulcer. This one is not being cared for adequately. You see the white area around that. That means that it has sustained prolonged moisture, and those edges, if we don't do something, are going to break down, and it's going to enlarge, probably on one side there, on the upper right hand side. There probably could be some tunneling. In other words, there's an open area underneath that skin. So you'll learn more about these as you go. Here is an example of periorbital edema. Okay, you would see this on your general survey. This could be a result of trauma, although I don't see bruising. More than likely, this could be a problem with heart or kidney disease. Ouch. This is a poor gentleman who has extreme scrotal edema. And men can have scrotal edema just like women can have sacral edema and edema in the feet. Of course, water follows the path of least resistance, and so this looks extremely painful. It is painful, but basically we just give supportive care. We're very gentle with our cleaning. We're very careful. Sometimes we roll up a towel and elevate the scrotum so that maybe the drainage will lessen. But this is pretty extreme. This is an example of clubbing and a little bit of cyanosis in these nails. You might see this in Raynaud's. I think I had a picture of that in the last class. These are pictures of jaundice. Now you see here the top picture there, it's a dark-skinned individual, and it may be hard to see sometimes the jaundice, but it's there. And then the bottom picture is a light-skinned individual, and the color's not real good on the picture, but it is definitely yellow. Okay, you're going to see that probably before you see the actual skin be jaundiced. It could be either one. And here is a picture of checking skin turgor on the elderly. We don't use the back of the hand because it's always going to tint, and that could be misleading. So we want to check around the clavicle, or just pinch it up, and it should retract, and that will give you the skin turgor for your elderly person. And I believe that is all for now. Thank you.